And I'm now going to turn the podium over to Dr. Christian Stensland. Thanks.
Thanks so much, Ian. Thanks everybody for tuning in. It's really exciting for me to be able to talk to everyone about some of the approaches that we've been trying to take to both design and test how we improve the clinical trials run within music. To kick things off, in terms of disclosures, I have some unrelated financial disclosures, but a lot of this work has been funded by the NIH and the Department of Urology at the University of Michigan that I'm very thankful for. So we're going to kick off with two main questions today. And the first one is why care about clinical trials in general, and specifically how they're run within music, and also why we should care about how we run clinical trials. And the rationale behind this is to really try to provide the best care for patients while also making sure we're minimizing all the negative impacts on the music stakeholders, including patients, of course, but also all of our urologists. So the big question here is, why should we care about trials? Now, of course, we know that well-designed trials can answer very real questions. Specifically germane to today is should I leave a stent or not after uncomplicated ureteroscopy? And the big issue here is that often without a clinical trial, we don't really know what's accurate. So while we have great retrospective data, even the best retrospective data, including from music, often can't replace a clinical trial. And we really do need a lot of this prospective data to answer questions where other confounding factors make it so we can't necessarily rely on those results. But in addition to these issues in general, there's a specific benefit to music specifically for running clinical trials. And part of this is that trials run in music can really reflect our own community's needs, and we can open trials that match specifically our own issues. Additionally, music data can guide our questions and also can help us pick which sites should run trials. So specifically, some of the trials that I've been involved in and we're running include the SOUL trial. We observed previously that there are higher ED rates for stented patients, but we needed to prospectively test this. We do know that this actually applies to our patients because of existing data, though. And similarly, when we go to pick which sites to run our trials in, for example, in our Brian trial that we're sending into PCORI in the next cycle, we saw that there was some variability in what the benign nephrectomy rates were, and some sites had lower benign nephrectomy rates, and it really impacted how we're designing that trial and which sites to put in it. On top of this, once we get the results from clinical trials back, these results from the trials that are run specifically in music should apply very well to our own patients. My past patients, for example, probably look a lot like my future patients, but also patients from other music sites are probably going to look more like mine than trials that are run in other settings like Denmark, for example. We also can find that we can implement the results directly in music afterwards. So once we know what works, we can roll it out pretty fast, and we can use our music tools to get the right thing to the right people at the right time. And you may say, fine, I've bought into the idea of clinical trials, but why should I care about how we're doing the trials, as in how are we implementing them? And specifically, one of the things I wanted to focus on is about clinical trial enrollment. So many folks have participated in the SOUL trial, and trial enrollment is actually really hard. And this is true internationally. Enrolling to trials is really the hardest part, and about 1 in 5 clinical trials will fail, mostly because of these issues with enrollment. And few trials ultimately complete enrollment in their planned time frame. And the big question here is how do we fix it, and why do you care? Unfortunately, despite over 75 years of clinical trials, nobody knows how best to enroll patients. And most ideas on how to enroll better are never actually tested, and very, very few are tested in their own randomized study. So what we end up with is we roll things out, but we don't actually know whether they're effective. And so if we do things just kind of ad hoc, we're not really going to be sure that what we're doing is making a difference, and is it worth the effort? So for example, there's a really simple fix, or there are a few simple fixes, one of which we tried within the SOUL trial. And the question here is can we just lean on music communication, kind of our existing music infrastructure, to improve enrollment to trials? And one way about this is like, can we just increase our direct emailing to folks about the trial, the same way that you advertise the collaborative meetings and that type of thing? And my question here is do you remember Soulvember? Back in November, we launched this campaign that you may remember in your inbox that was advertising for an enrollment push within the SOUL trial. This was a great thematic and entertaining emails, but also leaned really heavily on behavior change research that was looking at things like leaderboards and feedback and doing some packaging of advertising materials to try to improve enrollment, which makes a lot of sense. And so it makes sense that it would work to improve enrollment. But the question is did it actually? Anecdotally, yes, it did. 32 participants enrolled during the push. And the question is, was this more or less than we'd have had anyway had we not sent out all of those emails? Unfortunately, there's fewer participants than October, but it's hard to compare month to month, and the same participants as we enrolled in December. But again, number one, it's hard to tell based on the temporality how folks are enrolled. And also there are lots of other things that are going on at the same time, similar to a lot of the other initiatives that we do within music. In addition to these targeted emails or trial-wide emails, there are individual emails and other individual communication like text messages or just face-to-face chatting about trying to push for enrollment, as well as things like the collaborative wide meeting in October. So it's really hard to disentangle, was it our specific email push that worked or these other things? And you may say, why do we care? It's just an email campaign. It's relatively inexpensive, but why do we care? One reason is that it takes time to generate and send emails. Even for something that's relatively low cost, it's not zero cost. The other thing is if email advertising doesn't work, we don't want to clog people's inboxes, and we also don't want to distract from all the other great communication we have. So the question is how could we know if it works? And the easiest way is just to do it again, but this time we should control and measure how we send it out, which brings us to our actual intervention, which is the core of tonight, which is we launched this Soul Madness campaign in the month of March. This was thematic. You may recognize these from your emails. And this was, again, advertising around theming and enrolling into the Soul trial. But the question was how to send it. And what we did was we split all Soul providers who had enrolled folks into the trial into two groups randomly. And we paired them so the prior enrollment was similar between groups. And then we sent the first group advertising emails for 4 weeks, and then we rolled it over to the other. If you're interested in the protocol for this, we just recently published it. And the big question is did it work? Within the month of March, the email groups, the folks who were sending weekly emails to, enrolled 9 participants compared to 7 in the control group. So a minor difference. But then when we flipped it, when we started emailing the other group, they only enrolled 2 participants versus 5 in the control group. When you lay out how this looks, Group A was the first group who got emails, and Group B is the second group that got emails. And so focusing in here, you can see when we launched our trial from February into March, there was really no difference in enrollment. And then when you compare this back to Solvember, we also see that there was really not an impact at that point. As far as the current analysis goes, there's really no difference between these groups and enrollments, but there are unclear secondary benefits like maybe higher morale or engagement and some longer term benefits to enrollment. But limitations to this are small sample size and a short duration. We're still working on some next steps, including evaluating engagement, checking email receipts, and comparing to eligible patients to find out about absolute and proportional enrollment. We have a few next steps, including refining our messaging, getting some feedback from everybody on what messaging is helpful, and evaluating our engagement, including trying to find other strategies to promote enrollment and identify and overcome other barriers. And as a final closing point, we can also apply this to other interventions prospectively in music, and we're trying to build out the way to track engagement communications so that we can do these types of evaluations for all the other great things we're doing in music and prove their value. Thanks so much for your attention, and I'm going to pass it on back to Dr. Dauw for our next segment.
Thanks, Christian. So we're going to move into our last discussion here. I'm joined now by Dr. Christian Stensland, who just gave a great presentation, Dr. Ann Sales, Dr. Khurshid Ghani, and then Dr. Kevin Tim. Dr. Kevin Tim is not a urologist, but Dr. Kevin Tim is a great dentist and is a partner advocate for the Soul trial. And is going to share some insights for us here today. So kind of where I want to start, maybe, Kevin, is with you. Anne presented this really interesting data on patient perspectives around ureteral stenting. Maybe you could share a little bit about your prior stone history and kind of lean into why you personally felt like participating as an advocate for the Soul trial was something you wanted to do.
Yeah, I started my stone journey about 15 years ago. I've had, I think, 19 surgeries to remove kidney stones by this point. Some have been easy with single stones. Some have been multiple stones. I've had stents before, stents after, double stents. I've had a variety of different things. Take them out yourself, have them removed back at the hospital. And it's just interesting to see talking to other patients, I have my own patients who have had stents before too, and nobody's really happy with them. So anytime you can find a reason to not stint and do it safely, seemed like a good place to start a discussion, at least.
And if you reflect on what you heard from the folks you interviewed on the patient side, were there outliers? Did you hear from patients that said, yeah, actually, it's not a priority for me. Didn't really feel it, didn't care, wasn't a big deal?
Yeah, we did.
I think there's some of those as well. Every person's got their own level of pain tolerance and how much they're, comfortable with. I found stints. I had one in for 3 weeks prior to a surgery. And it just kind of became part of your life. You deal with it. You didn't really have a choice in the matter. It was there. It was for safety. It had a purpose, and you make it work. I trust the doctor's recommendation more than we just don't want to have one, because without one, I would have been in a lot of trouble on many occasions.
Was that your sense too, Anne, and kind of looking at the cohort of patients that you interviewed?
Yes, I think definitely. It was certainly a minority of people who said that some people said, I don't care. And other people expressed the same opinion that Kevin just did, which is, if my doctor thinks I need it, then I'm okay with it. And that was, I think that was true of most people. If they felt that that the procedure really required it, and that their surgeon felt that that was the right thing to do, they weren't upset about that. I think there is still the issue of trust and understanding that the person who's doing the procedure knows best.
So Kevin, tell me a little bit more about your motivation for participating, kind of getting behind the curtain into the weeds with this trial as an advocate. What led you on that journey? I asked you, but it's a significant amount of time for you. What are your motivations there?
Well, everybody's got a story, and I think based on a lot of what I've seen, the education part of it beforehand for patients who have never had a stent was a big part of what we talked about in a lot of the questionnaires and stuff. The first time I got one, I didn't know what it was or what it was doing or why it was there. And so having that education part, we've talked as well about, how to remove them and how that happens. And I think patients need the education. And I think that's the part where I was, hoping to help somebody get a perspective on what it was like to have one, so they know, how the patients are going to deal with this and how the patient's perspective is, so they can go ahead and be properly educated and ready for what's about to happen.
So Khurshid, I want to bring you in for a second. So, one of the things that I think is most impactful for urologists that are tuning into this webinar is understanding the patient perspectives. I truly don't think that this effort would have been funded without the work that Anne and her team are doing. And so, what are your reflections, kind of understanding these data, the structured interviews, and then your own clinical practice around the patient experience and how that's kind of either changing your practice or reinforcing your practice?
I think the biggest revelation to me that Dr. Sales and her team were finding is something that we just take so for granted, which is you have a stent and you're going to undergo stent removal. And I think it may have come up by Jan earlier on in the session. She says it's stressful having a stent, and it's stressful thinking about when it will come out. And we are a little bit, I think, so immune to this as urologists that you're just going to come to my office, we're going to pull out the stent. What's the big deal? And we learned from Anne's team that they're terrified about what that means. They haven't been educated about the procedure. And so one thing is I'm much more mindful and respectful now about the process of stent removal. And I think as a result of this work, we are, as you know, Casey, Music is trying to create now better videos and guidance on stent removal, educating patients. So educating patients around stent removal is not something I thought would be the first thing, with the biggest patient learning that I have on stent omission is actually the fear and terror of the stent removal in patients who are stented, because many of these patients do get stented, right? And that's what we're learning from some of that. I'll stop there. I have other things, but I want you to reflect on if there's anything else further, or Wilson, or other thoughts on what he's been learning.
Yeah, I mean, I in general completely agree with what you've said. I think that we all remember the one patient who you stented that had the most miserable experience ever. And that kind of, I think, was one of the reasons we went down this path. But more broadly speaking, I think what Anne said is really interesting, right? Patients are going to trust what their doctor says, and leave medical decision making and to the doctor's expertise. I think that that's part of the patient-physician relationship, and it's something that we take very seriously. That said, this is a kind of a nice segue for me, and that relationship in this particular scenario is based on our fear that we're going to potentially harm someone by omitting stents, knowing though that we all have those patients who are uncomfortable with stents. So maybe tell me a little bit more about what your big high level take homes were from interviewing physicians, because I think that's fascinating as well.
Yeah, I think the biggest was that people just expressed a level of uncertainty and discomfort with not using a stent. That omitting a stent means not knowing what's going to happen, even though when we ask them, well, when you have omitted stents, have you had bad outcomes? For the most part, with a couple of exceptions, for the most part, most people said, no, things have gone fine. It hasn't been a problem. But the uncertainty and the concern that there might be a bad outcome, in particular, that there'd be retention of the stone in the kidney, that the ureter would be blocked, that something else that could be really quite harmful to the patient, outweighs that sense of concern about the patient's well-being and the pain issues, which are the primary issues that patients experience.
And so, Kevin, you've kind of, again, using the analogy of kind of being in the inner circle here, you've been a part of the construction of this study with a very vital voice, which is the patient, right? Can you comment a little bit? I know you're not an enrolled patient in the trial like we had as Janice, but what is your sense from the multitude of phone calls that we've done around how we're trying to educate patients, recruit patients, and how do you feel about that as a patient who suffered from kidney stones?
I think the education part is always going to be the key. I mean, if they don't know even what a stent is, then they don't know why they wouldn't want one. And if they've got one and they're uncomfortable, what can be done? And if they're going to have it taken out, how is it going to be taken out? Because there's a couple different ways that can be done too. The uncertainty, which I think Janice talked about too. When is this happening? How is it going to happen? What's it going to feel like? All of those things create the, one of the questions in the earlier part was atraumatic. How atraumatic is traumatic? Or, in our minds as patients, it gets so much worse than what it really is. And then sometimes you go in and they pull the stent out. I mean, you removed my first stent. It was, 3 or 4 minutes or 5 minutes. It wasn't a very long procedure at all. And I'm like, oh, that's it. But then I've had other, stints that were much more complicated than that. So having an expectation and educating ahead of time is kind of always my thing. I mean, if you tell them about it ahead of time, it's information. If you're going to tell them about it afterward, it may sound like an excuse.
Yeah, that's insightful. I think one of the things that keyed in on Anne in your closing, and I want to bring Christian into this conversation. You'll forgive him. He's a urologic oncologist, so has no business being in an endourology webinar, but his clinical expertise extends far beyond that. But Christian, I think the question that we're all then left with is, let's say we conduct the best, clinical trial possible. We've gotten the patient voice, we've done things right, and we show that, perhaps stent omission is not harming patients, right? And that on the flip side, that patients are actually really uncomfortable with stents. How do you then go back to urologists and implement something like this? And I know, Anne, you're a world-renowned expert in this same space, but Christian hasn't said anything yet. Where does your expertise, Anne's expertise, fit into that sort of the discussion? Because that's really where the rubber meets the road. You can do the best study ever, but if everyone says, yeah, I'm not going to do that, then where do we go?
Yep. Yeah, it's a great point. Thanks. I will add, I have actually enrolled to the SOUL trial during my limited clinical time, despite my urologic oncology training. That's it. Yeah. Putting my money where my mouth is. But yeah, it's a great question. I feel like, as Anne knows, as one of my mentors in implementation science, a lot of this is even if you have great randomized trial data, it either never gets implemented or it takes years and years and years to get it in place. And so this is part of the rationale, as you know, for the SOUL trial itself of getting designed to give outcomes and inform data on things that are important to all the stakeholders. So urologists who are ultimately making the decision in the OR to put a stent or not. And why is that? And what are, as we say, the barriers and facilitators? So what's leading to us putting a stent in, what's stopping us from putting a stent in, or the reverse of what's keeping us from leaving it out or doing it, what's encouraging factors, and then how do we test the different strategies. So if you say, oh, it's that people don't understand, we're not understanding the patient perspective enough for things like how painful a stent can be or the anxiety surrounding it, then that informs or it implies a certain strategy that then we can say, well, maybe we need to do some type of an educational intervention to give that perspective to urologists, and then decide how valuable is that? And when we deliver that, if you only have a certain amount of messaging you can give, what's going to be most effective? And that's regardless of what the results of this trial are, which is really nice and a great transition point in that sort of last leg of this is figuring out whatever we find, how do you get it into the hands of the people who need it? And again, getting stents where we need them and not where we don't.
Yeah, and if I can bring in Dr. Sales here on this, I mean, we had this discussion, and you gave a very insightful comment, and about it's a training thing, and we heard that from Wilson, we heard that from John. Mm-hmm. They didn't train, they didn't know how, then they got trained and they know how. And you said, and if this is if the trial's findings are as we hypothesized, then the AUA and the associations, the Endocrinological Society there'd be some implementation steps on how to train people to do stent emission. What do you think?
I totally agree with that. And I think, training, what underlies training is people's self-confidence and their sense that this is something that they can do comfortably. It's that sense of uncomfortableness that I think drives a lot of decision-making, especially in a situation like an operating room procedure that's underway. You've got time pressures on you to get the procedure done, to do it well. And your decision is going to very much depend on what you know and what you're comfortable with. So if you've not received training, then it's very unlikely that you will decide to omit a stent unless you feel 100% sure that this is an entirely uncomplicated procedure. And that's rare. It's unusual not to feel some level of discomfort and look at the situation you have and think about it and decide, I want to be comfortable. I think I'll do the thing that seems safest.
Yeah, I mean, well said. I think what I take from this is that, we've done a tremendous amount of work getting things to this point. Kudos to Khurshid. And I should say, from reflecting on your slides, Christian, a lot of those initiatives came organically out of the team that is running the SOUL trial, which by no means is just myself and Khurshid Ghani. But people that attend a 20-minute meeting, there are people that are living this, 7 days a week to recruit patients, think of ideas like SOULvember or Soul Madness, et cetera. So it goes without saying that we couldn't be doing this without them, but really the work's just begun, right? We hope to conclude this trial, but really it's going to be where we go from here, and help from experts like yourselves and the input of our great patient advocate, Kevin Tim, where we're going to be able to take this to the next level. So thank you to our panelists. I'm going to move just kind of into some brief take-home messages here. And so it's really hard to distill down, what was a tremendous hour and 15 minutes of content here. But I think as I'm reflecting on where we're at currently with the SOUL trial, my hope and I think my strong feeling is that the conclusions of this trial are going to provide high quality evidence regarding the safety of stent emission, whether it be one way or the other. I think it's going to inform practice, and I think that's key. I think we heard very well from two urologists who trained in very different ways that you can embark on your journey to stent emission with easy cases, right? Start with the low hanging fruit. Don't choose the most complex cases to begin to attempt stent emission. But do realize as you're going down this path, the data has suggested time and time again that while it is a fear or uncertainty, and said multiple times from our physician interviews, it is a lot of uncertainty, but it may be unfounded, right? Obstruction and need for stent placement in the setting of stent emission is very, very uncommon. In the music literature and in others, it's far less than 1% of the time. So take comfort in that fact, especially as you're using some of these more straightforward cases. We heard time and time again and had some great videos from Dr. Gupta around the idea of smaller scopes, specifically the 6.3 and 7.5 French disposable scopes, or reusable scopes for that matter, that may facilitate stent emission. These are definitely things that I'm employing in my practice with great results. I think it removed some of that uncertainty for me personally, and I think we heard that was probably the case with Khurshid and others. It is pretty clear to me, and based on the results that Anne has conveyed today, that most patients prefer stent emission, not all, but most. But we do recognize that our own clinical biases as physicians and uncertainty do result in stent placement. And so these are things that we need to balance as clinicians, but also need to hear when patients come to us. And then finally, I think, Christian, you did an excellent job highlighting that trial recruitment is challenging. We are surrounded by an incredible team that is going to get this trial over the finish line. But we are and will continue to pursue innovative ways to maintain accrual so that we can